Welcome to our webinar series for professionals.
So welcome everybody to this webinar that actually has been a bit of a dream from my side for a while, maybe even a couple of years. Anyway, I'm Anne-Catherine, co-founder of Nordic Laboratories and DNA Life, a group of companies that are just dedicated to support health and maybe change healthcare through functional medicine strategies. So, and of course, we are not just about lab tests or supplements. We are about education, treatments, and really supporting you as practitioners the best we can. So just before we dive further into this, I'll just introduce you to a kind of save the date. If you want to visit Copenhagen, then I suggest you put a cross in your calendar for the 1st to the 3rd of November this year, where we have a Nordic conference. And we will be having Dr. Carrie Jones will come and talk on hormones. And we will have Dr. Brady in regards to GI map and autoimmunity and gut. Then we will have other educators around organic acid testing and genetics, of course, as well. So I hope to see some of you then in Copenhagen for sure. We will send out links and information in the next coming weeks. I know on Monday, I think for sure we are sending something out. But today it's all about SIBO and gut health. I have invited Dr. Nirala Jacobi into the scene here. And the reason why I say this has been a bit on my wish list for a couple of years is because that was when I was introduced to Dr. Jacobi's podcast, The SIBO Doctor. And I think I've listened to every single episode and some of them a couple of times because I thoroughly enjoy the talks that Dr. Jacobi has with her guests there, and I learn a lot from them. So I can highly recommend those to you all as well. At the same time, she's a master when it comes to SIBO, she offers education around SIBO to practitioners, and she has a podcast, and then she's also the medical director of a SIBO test in Australia. So, and that's why we are working together, because we are also offering a SIBO test just around the globe. But in that way, we are colleagues. And that's why I wanted to invite her in here, because she has so much knowledge and clinical information that she can share around all things SIBO. So today is about difficult cases in regards to SIBO. And as usual, you can put questions in the chat box. I'll take note of them, depending if you overflow me. I can't follow up, but I'll try and keep so that we can do a Q&A at the end of the session. And then for those of you, what I'll try something new a little bit today is I'll hang on after Dr. Jacobi finishes her talk and the Q&A is done. I'll hang on and then go through Nordic VMS for some of you if you are interested in that. So just to hang on for those few of you who wishes to partake in that. But for now, I'll mute myself. We are recording, so we will send out the recordings and we will share the slides as well. But I'll mute myself and I'll be assisting on the side. And then I'll pass on the stage to Dr. Jacobi and all things SIBO and difficult cases on SIBO. So you're in for a treat. So thank you very much for joining us. Dr. Jacobi, the stage is yours, so you can now share your screen.
Thank you, AC. Okay, let's see if I've... Okay, first of all, this is so great that actually everybody's camera is on. It's wonderful to see you all around the globe. I'm in my cold little office. It's winter time in Australia. We've got a fire going, so it's just really nice to see people in Nordic countries in their summertime. So one of the reasons I'm really passionate about SIBO cases or SIBO in general is because I've really dedicated the last, I'd say, decade to, hang on, let me just figure out if I can advance. Yeah, I really dedicated the last decade of my clinical experience to SIBO. I was a naturopathic doctor practicing in Brisbane in Australia, and I first heard about SIBO when I went to a conference in America where Dr. Siebecker spoke. And many of you who are familiar with SIBO are familiar with Dr. Siebecker, and she has done a lot of amazing work of bringing the alternative community really up to date with some of the research. And her and I are good friends and colleagues, and so we sort of I started a little bit behind her, but basically I heard about SIBO in 2011, and I was a bit flabbergasted that I'd never heard of SIBO before, because probably like many of you, I had patients that gut patients that were just not improving, even though we thought we figured out, I thought I figured out what was going on with them, and they were just not getting better. So when SIBO first came on the scene, I thought, this is it. This is the missing link. And it certainly has been the missing link for many of my also very recalcitrant patients. So then I said, this is too difficult to tackle without some guidance. So I created the SIBO biphasic diet, which is basically a two-part approach to the treatment. It accompanies treatment. And many of you may have heard about it, and it's been downloaded many thousands of times. And every day we get feedback about how helpful it has been. And it is now an updated ebook if you haven't seen it yet, but it is much bigger. It has a lot more recipes, and it's also still very popular and helpful. The SIBO Doctor podcast has been going for about 8 years now. So I am on a little hiatus from practice and also from podcasting. So I'm on a little bit of a sabbatical from that at the moment, but there are some really amazing guests on there that can elucidate many of the questions that you have about SIBO. I really have interviewed Dr. Pimentel many times, Alison Siebecker many times, and many of these subspecialties that also tie into SIBO. I am I'm in the world of SIBO with testing. I have my own breath testing here in Australia, and I have an education platform where I educate practitioners like you about how to properly treat SIBO. As I mentioned, I'm a bit on a sabbatical from my practice. That's my clinic is currently closed. I'm not accepting any patients. But the big question is, what causes SIBO, right? And that's really the focus of tonight's or this morning's talk. It's tonight for me. So if it was just bacteria, right, none of us would be really all that interested in a webinar of what to do about the bacteria, because we're very adept at using herbal antimicrobials for various dysbioses of the gut. For me, as a naturopathic doctor, my passion has always been treating the cause, because that's one of the tenets of naturopathic medicine is treat the cause, don't just treat the symptoms. So I'm going to focus on 3 areas of underlying causes that can really kind of hopefully broaden your perspective about the treatment of SIBO. Now, as I mentioned, if it was just about bacteria, pretty much all of us would have SIBO probably all the time. There are different mechanisms that the body uses to flush bacteria out of the upper gut. So as we know, SIBO is a bacterial overgrowth in the upper gut, in the small intestine, and it causes a lot of symptoms because of the fermentation of food that causes gas production in the small intestine. But why is this happening? We have lots of different mechanisms that prevent this from happening. So basically, I have created sort of a pie chart that you'll see in a moment, where I go through the different categories of underlying causes, and I have 3 cases to highlight these different areas. But let's say the first area of underlying cause is something is wrong with your patient's digestive function. So either not enough stomach acid, or not enough bile, or not enough pancreatic enzymes. And together, these digestive juices are quite bacteriostatic. They prevent bacterial overgrowth, especially stomach acid. So don't underestimate the power of digestive functions or the lack thereof in really causing some of the SIBO that you've seen in your patients. So that's one category of underlying causes. Then the next category of underlying causes is something is impairing the motility of the small intestine. And this particular category of dysmotility is big, and we'll get into that. There's lots of different reasons why the motility of the small intestine can be impaired. So bacteria essentially are not flushed out properly out of the small intestine and are therefore allowed to remain and ferment the food that is abundantly available in the upper gut. And the third category of underlying causes is something is happening to the anatomy of the digestive tract itself. And this is often due to adhesions that is caused by any sort of abdominal surgery. So whether it's a hysterectomy or a C-section or an appendectomy, or you name it, all of these, what we would call pretty routine abdominal surgeries, can actually cause a lot of adhesions, including also endometriosis. We mustn't forget that, of course. So this is what I call the kink in the garden hose scenario, where the anatomy is pulled to some side or somewhere where the flow is not really naturally flowing. So there's some alterations in the anatomy of how food and the bolus of food flows through the intestinal tract. So that can often occur when you see patients that have had abdominal surgery. I always consider that as an underlying cause at this point. And I have had many where you just can't clear SIBO until you actually address this. And you will see this in one of the cases that I will present tonight. So when you think about, all right, these are the categories, the fourth category would be medication, any kind of opioid, for example, that slows the gut. But this is typically a lesser underlying cause. So this is by the pie. I don't know, can you see my mouse when I move it on the screen? Yeah. So for example, the motility category is the biggest category. So this is often, and as you'll see, this will really play a big role in many of your patients, because as we know, for example, a case of food poisoning can damage the migrating motor complex in the upper gut, which is part of the motility of the small intestine. But there are lots of other reasons why motility can be affected. And then digestive deficits, medication, and any kind of adhesion. So when we look at the different conditions that are in these categories, they're pretty extensive. So in the impaired motility, as I mentioned, the autoimmune IBS scenario, where you've had a patient that went to Bali or went to even a local salad bar and had food poisoning, and then basically ended up with IBS, sometimes 6 months later, sometimes a year later, not usually that long, but they never really fully recover, and they really develop this IBS type scenario. I personally don't think that's necessarily the most common cause. In my practice, for the last decade, I have seen pretty much everything you can see presenting with SIBO as the primary concern, but there were lots of other reasons why that person developed SIBO. Yes, oftentimes I do hear that there is a food poisoning in somebody's past, and I have had the technology where I could check for the antibodies, and they were not always positive. So, but anyways, let's say that that is a very common cause of SIBO. Then traumatic brain injury, right? Think about people that have had car accidents or fell off a horse or had any sort of accident where they lost consciousness. Hypothyroidism, we know, of course, it affects motility. And then chronic infections, often overlooked, things like EBV. We see COVID now, of course, but also Lyme disease. I don't know how prevalent that is where you're practicing, but in certain areas, okay, AC is nodding. So yes, we always have to worry about any kind of infection that affects the central nervous system and the autonomic nervous system. And then mold and chronic inflammatory response syndrome. Dysautonomia, these are the more advanced kind of conditions that affect the autonomic nervous system, like Ehlers-Danlos syndrome. And Ehlers-Danlos syndrome is actually a connective tissue disorder, but it's quite prevalent. It has a similar prevalence as celiac disease. So it's actually quite common, and you will have seen patients. These are the super bendy people. They're often gymnasts and work for Cirque du Soleil and things. I mean, I don't know, but I'm just saying they're very, very flexible and often have issues with their connective tissue. And of course, the gut is connective tissue. And then POTS is postural orthostatic tachycardia syndrome, and MCAS is mast cell activation syndrome. These are the more advanced contributions to issues around SIBO, and then scleroderma, the autoimmune condition. Whoops, sorry about that. Where's my mouse here? Then impaired digestion. Of course, we know that many people have microbiome dysfunction as a result of impaired digestion. And if a lot of the new research that's coming out from also Dr. Pimentel's group has done a lot of research into the microbiome of the upper gut. So we're seeing that there's a lot of dysbiosis in these SIBO cases. And we know that certain antibiotics taken long term can cause a lot of dysbiosis. I'm not saying that everyone that's taken antibiotics ends up with SIBO, but obviously if you disrupt the normal microbiome, there can be issues around that. And then the chronic stress, fight or flight response, the autonomic nervous system, this is also affecting motility, of course, but anybody who is in this very activated sympathetic nervous system state will have impaired digestion. I see this time and again. We have issues around digestive releases with hydrochloric acid and enzymes being not released because you require proper stomach acid for enzymes to be released and so forth. And then a host of other issues like secretory IgA deficiencies can also be resulting in SIBO, poor bile flow, that's very common as well, and low stomach acid. And then low brush border enzymes. So these are separate or different from pancreatic enzymes. These are actually enzymes that live in the little microvilli of the small intestine and are actually perform that last step of absorption, digestion and absorption for us. And oftentimes, SIBO will result in brush border deficiency and vice versa. So digestive deficits are definitely an issue that we see with development of SIBO. And then again, these adhesions that I talked about, Ehlers-Danlos syndrome, again, is very, very common with this. Endometriosis and any abdominal surgery, but then also ileocecal valve dysfunction. And the ileocecal valve is the valve that connects the small intestine or the terminal ileum to the large bowel. And sometimes this can be chronically stuck open for different reasons. So those are the main categories, and then certain medications. But I always think the medication side is a little easier to deal with because once you stop the medication, that stops the impairment of the motility. And so I've listed here the medications that can interfere and be an underlying cause of SIBO. So let's go into the cases. I have 3 cases for you that will, and these were really, 2 at least were extremely tough. I know that we've all had cases where we're sort of like at our wits' end. What am I doing wrong? Why is this person not improving? I know I'm doing the right thing. And so I'm giving you 2 of my toughest. So let's see how we go. So the first one, this was a few years ago. And actually, I'm going to have to move. Hang on, I'm just going to see if I can move this off the screen. So this was a man in his mid-30s who had classic SIBO symptoms of bloating after meals. But he also had this burning of the soft palate and the uvula and throat. And that had happened since the wisdom teeth extraction that occurred 14 years before. And he had had this ever since, this burning sort of throat. He'd been checked for esophagitis and things like that. And basically, they found nothing really wrong. He was super reactive to supplements and medications. You all know those patients that react to everything, and you got to microdose and you got to go super slow, and they can't swallow pills, and they have all these restrictions. He was diagnosed with laryngeal and vagal neuralgia, Hashimoto's thyroiditis as well, and he'd had this fundoplication, which, for those of you who don't know this procedure, is a really common procedure for gastroesophageal reflux. So acid reflux, they basically take the top of the stomach and they make a little turtleneck around the lower part of the esophagus. And it's for those that have a very floppy lower esophageal sphincter, which keeps the stomach acid obviously in the stomach and prevents the reflux. So fundoplication he's had, and that didn't do anything, unfortunately. So he had been on a proton pump inhibitor for 8 years, Zantac, which is a different type of H2 blocker, also antacid, and also Gaviscon tablets. So he was on maximum of suppression of hydrochloric acid with very, very limited result or symptom relief. He came to me, had already done a lactulose. He'd seen other practitioners. So by the time he came to see me, and this is often what happens, a lot of practitioners have done great work. They've done everything I would have done. And then they come to me, right? So this was a case where he had always been negative on lactulose breath test. And so this very astute practitioner had done a glucose breath test. And it was, as you can see, the numbers are just off the chart, literally off the chart. So I think this was one of the first times I'd seen really hydrogen levels on glucose that high, to be honest. And I think glucose definitely has its role, glucose testing, and when it's positive, it often is positive, very positive when lactulose is negative. So he had been on multiple rounds of herbal antimicrobials before seeing me. So I said, all right, you've never tried rifaximin, which is, of course, the treatment of choice in terms of antibiotics for SIBO, and because it stays in the small intestine, it's bile soluble, so not water soluble. So there's lots of reasons why rifaximin is really the preferred antibiotic for SIBO. And so he did the normal dose of 550 milligrams 3 times a day for 2 weeks. And he did 2 times 2 weeks because those gas levels were really high. I said, let's just retest the day after the completion of the last round of rifaximin. So for those of you who work with Nordic, have seen test results through aerodiagnostics and stuff, it looks a little different, but the numbers are as the same space. So here we have a 3-hour breath test. And at baseline, this is the morning of a breath of the patient is basically has fasted overnight and is taking their baseline sample. Then they drink the substrate, whether it's lactulose or glucose, or in some instances fructose. And then every 20 minutes, they take their breath sample. And anything over 20 parts per million is considered positive. So basically, he was positive immediately after consuming this substance, which is also significant if you look at the timing. It's really unusual to see this jump in the first from baseline to 20 minutes. So we know that it's quite proximal SIBO, meaning very high up in the upper intestine. Again, this was a glucose, right? So then I said, all right, let's just retest. Let's see where we're at. And I often do this. I recommend retesting because if you just went by symptoms, you would continue to treat people even if their breath test is negative. And I often use breath testing to make sure this person has really only SIBO. There's nothing else going on that's contributing to their symptoms. So what we found after this really heavy rifaximin was virtually unchanged hydrogen levels. Well, actually, I shouldn't say that's not entirely true. That first reading was quite significantly lowered. So we made small inroads, but definitely not anything near what we normally see with rifaximin. So then I said, let's just try the elemental diet, because he'd never done it, and let's retest after that, because what I wanted to find out is what is going to move the needle. I need to know if his symptoms are all due to SIBO, or what's actually going to eradicate the SIBO before I can move on to underlying symptoms with this person. Whoops, I keep doing that. So he came back. He said he was on death's door after doing the elemental diet for 2 weeks. He felt the worst he's ever felt, diarrhea and nausea throughout the elemental diet. And I don't know how many of you are using the elemental diet. I love it. It's a great treatment for very high gas levels. And it's very effective. It really is, but it's tough to convince people to do it. And most people prefer to just do antimicrobials and the diet, etc. So it, however, had made quite a difference to his gas levels. He was still positive. But so halfway through the elemental diet, I actually added this combination liquid tincture to his treatment plan, because I felt like, this is so close. It's probably in the duodenum, that if I give him a capsule, it's just not going to go anywhere. With that much acid suppression, you're basically like those capsules, how long does it take before a capsule can open? So I basically said, let's just retest you after, again, after 4 weeks. He really hated me at the end of that, because it's not easy to do those tests, as you know, especially with glucose, and especially if you become symptomatic. And finally, we got this negative test, right? But he did not have significant symptom relief, which is important to know. So SIBO is there, but it's not all what's going on with him. So I basically ordered an organic acid test due to the burning quality of his symptoms and the increased fatigue and the bloating on the elemental diet. The elemental diet does have glucose in it, and some people that have fungal or mold issues become very symptomatic. But at least we had a baseline. We knew that those levels were so low now that his symptoms must be also due to other causes. So the organic acid test revealed that he did have some mold markers. The marker number 2 and marker number 4 are mold markers. And then we have number 7, arabinose, which is more associated with candida. He did have a candida overgrowth for sure, but I was more concerned about these mold these mold markers. So we did an aspergillus, we did mycotoxins, everything was negative, and the ochratoxin A, which is an aspergillus mycotoxin, came back positive. Granted, not huge, I've seen far worse with ochratoxin, but significant enough where I said, all right. And also he had these wisdom teeth and removed. Let's just see what we find on a nasal swab. And we did find Marcon's positive, aspergillus was there, and also another mold. So basically at the time, I felt like I needed to refer him to a mold specialist, and he has done remarkably well with mold treatment. I was working with a mold specialist in my area. So mold can actually affect the motility of the digestive tract, and that's because mycotoxins are toxic to one of the central nervous systems within the gut, which is called the myenteric plexus, as well as the vagus nerve, which is of course a cranial nerve. That innervates big parts of or large tracts of the digestive tract. So I referred this patient to a mold specialist. He was doing much better. What did I learn from this case? Firstly, that if symptoms strongly suggest SIBO and the lactulose breath test is negative, do consider an alternate substrate, and that can be glucose. Nowadays, practitioners are also doing fructose. Also, I learned, yes, the elemental diet is indeed very effective in bringing those gas levels down. And herbal tinctures or combinations, I don't know what your availability is in the various countries that you're dialing in from, but I have used a lot of liquid tinctures, and they're excellent for this proximal SIBO issue of where bloating occurs really, really quickly. So we know that SIBO was not the underlying cause of his symptoms, but the underlying cause of his symptoms caused his SIBO and his SIFO. I hope that makes sense. And then I also wondered if because it sort of started when his wisdom teeth were extracted, if that had triggered some sort of sinus biofilm formation, and this whole neuralgia situation started for him. But he did discover mold also in his house, so that was another, obviously, is a factor. And I in the last 5 years, we had terrible flooding here in the northern rivers where I live, and we've had massive mold problems. So, and I think everybody in my area, practitioner-wise, had to become a mold specialist, pretty substantial mold specialist. And if you go to the SIBO Doctor podcast, I did, I think, 2 podcasts with Dr. Jill Christo where we talk about this issue of SIBO and mold. Okay, so this was a case of dysmotility due to mold, right? So this is John's underlying cause of SIBO. Now, moving on. Oh, he was also on proton pump inhibitors. That's right. So he was. He also had medication that can, in the long run, cause SIBO. Now, this was more of a sort of an easier case and sort of a combination SIBO case. This was a woman who said to me, "I suffered from constipation all my life, and symptoms included bloating and belching and constipation and mild fatigue. And she basically had no bowel movements unless she took massive amounts of magnesium and partially hydrolyzed guar gum and herbal laxatives. So she was quite hooked on herbal laxatives. She did get food poisoning when she went on a trip to Sri Lanka, where she had stomach cramping and this kind of weird sensation of writhing in the abdomen, and no diarrhea at all, but just this sort of nausea and ill feeling, and symptoms mostly resolved on metronidazole. She'd been diagnosed with Hashimoto's thyroiditis the year before, and she was on a combination T4, T3 medication. And she felt mildly improved, not really dramatically improved, but she felt a little bit better. But the constipation never budged. I know we've all seen patients like that, right? These kind of really recalcitrant, constipated patients. She also came in with this lab that she'd done through another physician who had suspected mercury and some sort of heavy metal poisoning. And this was a blood test. And as we know the half-life of these metals are not, they disappear pretty quick. I think it's 24 hours for mercury. So there definitely was an exposure, and she was eating tuna, canned tuna every day. So this is something that I think a lot of people know about. And I mean, I haven't touched deep sea fish or let's say canned tuna in many years because we know big fish bioaccumulate heavy metals. So mercury was high. And also look at her lead levels. Now, lead is classically associated with constipation, but not at these levels. But again, it was blood, which is not a good way to assess body stores. So this was just an aside. I thought I'd put this as well in here because it's interesting as a practitioner. Now, she'd also had done a lactulose breath test 8 months before and had received multiple rounds of antimicrobials at the time. There was mild improvement, not really done any retesting, and symptoms continued. And as you can see here, this is a different looking graph from a different lab. Hydrogen was negligent, right? But methane was pretty stuck in the 60, 70, 80 range, which is very high levels of methane. And methane, we know, causes constipation. So I said, I cracked the case, right? Of course, it's easy. It's intestinal methanogen overgrowth. So I did EMO. EMO is now the preferred name for SIBO-C, which we used to call constipated SIBO-C. But intestinal methanogen overgrowth is far more accurate because, as we know, methanogens are not bacteria. They're a different organism called archaea. And so it's a just better acronym for this condition. So I did high strength Alimed, like I always do. I did also berberine, because wherever there's methane, there's also hydrogen producers that are feeding into the methanogenesis. So I often use high dose berberine as well. And I use PHGG as well, because PHGG, or I just basically tell her to stay on that, but PHGG has shown to mildly reduce methane levels, not to that, like you can't just use PHGG with methane levels like that. And then I gave her the biphasic diet with added flax seeds, because also flax seeds are very good for with methane levels. Usually with flax seeds, they're pretty tolerable, even people that are sensitive to FODMAPs. And I told her to retest at the end of the 3 months. And so made significant inroads on the emo front, and virtually no hydrogen, but almost at normal levels now, methane, right? And if we, and Gary and I from Aerodiagnostics, we have this ongoing methane conversations about, and what we're really waiting for is a true consensus of reference ranges for methane that are actually really accurate, I would say. So, but for the, we report anything positive over 10 parts per million anytime during the test. So at this point, but she'd gone from 83 to the highest point of 14 at 160 minutes. So she was feeling better, but there was, the constipation persisted. And so I said, all right, let's just do a stool test, which of course most of us would have done already, and I did. But for the sake of argument, we're like, all right, let's just do, let's have a look at what's going on. So what we found was that she had really quite elevated fecal fat. And what that tells me is either there's something going on with her pancreatic enzymes, which wasn't the case because her elastase was normal, right? Above, you can see that. But her fecal fat was so elevated that I was really questioning her bile acids, her bile acid production. And bile, this is for me, when I hear I've been constipated my whole life, this is now the first thing I think of is some kind of bile flow problem. Because it is so prevalent in people that have very sludgy bile, that have, that have even SNPs in the UTG SNPs that have issues around bile production, etc. So in this case, I'm not saying this test can actually tell us whether or not this person has bile acid issues, but the fecal fat was so high, and anyways, I suspected that. So also she had high products of protein breakdown. This is an old, I think this was doctor's data. No, Genova. This was Genova, but this is a few years ago, but they've changed how it looks. So I don't know if they actually still do that. It looks a little different now. But whenever you see high products of high protein breakdown elevated, either that person is like on some carnivore diet and is eating really overwhelming their system with too much protein, or their hydrochloric acid levels may be low. So that's another little clue. So what did we do? And she also had a picture, a dysbiotic picture that favored high fat consumption as well. So like she was eating more saturated fats. And normally you should be able to release enough bile to emulsify those fats and absorb them. So it still doesn't explain the high fecal fat situation, especially in a constipated patient. If a patient has diarrhea and high fecal fat, that makes more sense. It was too fast going through and you just had no absorption of that fat. But in a constipated patient, that's significant in my book. So her Bacteroidetes phylum, so, as you know, the microbiome, 90% of it is comprised of these two phyla, the Firmicutes and the Bacteroidetes. They're sort of the main phyla. And whenever the Bacteroidetes phylum is elevated like that, I do think about high fat, high meat consumption that really favors the growth of these organisms. And yes, she had normal butyrate producers, which was good because butyric acid is also a really important motility agent in the gut, the short chain fatty acid. So basically, I said it's improper protein digestion leading to putrefaction in the colon, likely due to hypochlorhydria, possible lack of bile as well. Patient did have high fat consumption, as I mentioned, but it was beyond fecal fat levels were beyond that. And then what I did is I said, all right, for the next 3 months, I just want a low-fat vegetarian diet. I did give her 3 colonic hydrotherapy sessions in a row and then 1 enema per week. And sometimes that's helpful for retraining a colon that's been so it is a retraining because that colon has been lazy for practically 60 years. So sometimes we alternate water, like this is beyond the scope of this talk, but this is what I did. And then I also gave her bitters, which is the perfect treatment plan for her because bitters increase stomach acid production, but also bile flow, especially with dandelion root in there. And I also gave her a herbal prokinetic with artichoke and ginger, which is mild compared to the prescription, but still it works sometimes very well in combination with bitters. And then I gave her a probiotic that with this particular strain, Bifidobacterium lactis HNO19, which has been extensively researched in the case of constipation. And she came back, let's see, basically bowel movements daily, all of her symptoms resolved, her fatigue resolved. She stuck with the vegetarian diet. She really felt much better on that. And loves the herbal bitters and takes hydrochloric acid with higher protein meals and was able to discontinue the herbal prokinetic. So Ellen's underlying cause of SIBO was hypothyroidism, poor bile flow, and low stomach acid. So she had 2 categories of underlying causes involved here. But the hypothyroidism I felt like was being controlled. But there was this German study in 2018, just FYI, that looked at hypothyroid patients that were on T4 medication only, like Synthroid, or I don't know what you call it in your countries, but and it actually had much higher prevalence of SIBO in those people that were on T4 medication only. So that's important to know. With her, the lesson that I learned is that methanogen overgrowth is not always the cause of chronic constipation, even if methane still in positive range on a lactulose breath test. So technically, she fit the criteria for EMO, but as you can see, sometimes that last little bit, you just have to kind of consider the effects of this very, very slow motility and overgrowth in general. So I often do stool tests, but I pretty much think most of you would consider a stool test as well. But it's just nice to know that you don't have to continue to chase numbers on a breath test. You can also look at other underlying causes and much more the bigger picture of how this all fits together. Okay, last case. This was one of my favorites. She also a woman in her 60s, and she had chronic abdominal pain. And she had left no stone unturned. She also I was kind of her last resort. She had anxiety and panic. This was random, but a common reaction for her with certain foods and supplements and she was on different certain medications, like I think it was if she took ibuprofen or paracetamol or something like that. She had bloating, also constipation, and burning bladder, very burning bladder. So I was thinking interstitial cystitis. and possibly hydrogen sulfide, right? Just with those symptoms alone, I would consider that. But she had these sharp abdominal and pelvic pain episodes that varied in intensity, but were always there at some level. She had a very significant surgical history. She'd had her appendix removed. She had a total abdominal hysterectomy and bilateral, basically total hysterectomy. And transvaginal mesh had been placed to prevent organ prolapse. And then she, even the surgeon that had placed this mesh had already said there was a lot of adhesions intra-abdominally from these previous surgeries. Her first lactulose breath test, it was just a clear-cut case of SIBO. It's 80 minutes. We're seeing a rise of 39 parts per million over baseline. Her methane wasn't all that significant at all. So I was like, okay, this is a case of SIBO. I also, because of her antibiotic history, just did an organic acid test and found a little bit of yeast. And what then eventuated was me trying to chase the numbers, right? And this actually was a case that was about, I think it was maybe 8 or 9 years ago. So I love this case because it really, we sometimes forget about these things. So she'd been on, herbal antimicrobials and antifungal combinations. I gave her herbal analgesics that did help. These, some of these are very helpful for these chronic gut pain situations. Probiotics, her anxiety improved, but never, ever cleared SIBO. And one of the most significant things that happened is I was like, right, let's see if we can just get things moving with this constipation. If the constipation is resolved, maybe the pain will lessen. And I recommended that she do a course of procalopride, which is the prokinetic of choice in the case of SIBO. And I just basically recommended 0.5 milligrams. But the pain intensified with this, which was the kind of the thing that cracked the case in a way. So the abdominal pain persisted. I referred her to a visceral manipulation therapist, and I do recommend you all get to know someone that's maybe local that you can refer your patients to, that's trained in visceral manipulation. That's very different from getting an abdominal massage or any of that. So I usually refer people that I refer to the BoralInstitute.com has a database of treating practitioners. And he sent me this report back, this particular visceral manipulation therapist, and it was spot on. Basically, everything was restricted. On examination, there pronounced restrictions. Everything was stuck together with these adhesions. She had also a rectocele, a cystocele, and a urethrocoele. So she had a lot of collapse in her structures. And she had multiple sessions with some improvement, but minimal improvement with the pain, the painful urination, the urinary urgency, and the incontinence and obstructed defecation. So this is when we started to go down what's going on. And she actually started to do a lot more research into this mesh that had been placed into her abdomen. And this was a letter that she showed me from the meshinjuredaustralia.com website. There's actually a website of all these people that were injured with this mesh that had been placed into their bodies. And she basically had developed this chronic pain as a result of this mesh surgery. And I left it in the notes just so you could read what this surgeon wrote in his letter, and you can read it on the slides later. But she was then part of this landmark case, class action suit against Johnson & Johnson, because they used the wrong type of mesh for all these bladder lifts for these women. That was not ever meant. It was meant to be hernia repairs, but they used it for these bladder lifts. And so this was a big deal for her, and she had to find a surgeon that then, like, it was a big deal, had removed this completely stuck mesh could only remove certain parts, but even that little bit, she said that a weight had been lifted from her. So it was just really basically the result of the mesh that was at the root of everything in her case. And then as soon as that happened, the last breath test that we did was about 4 years ago, actually, and she was fine. She was at this point pretty much just borderline at best, but fairly negative for SIBO. So for her, obviously abdominal surgery and adhesions was the underlying cause of her SIBO. The lesson that I learned is that prokinetics will worsen abdominal pain in those that have pain from adhesions. If the pain is due to adhesions, very often prokinetics will actually make a situation worse. Visceral manipulation is helpful, but cannot overcome these mechanical problems and implants and continually that trigger these adhesion formation. And now she's on the road to, she's already recovered, but there'll always be some, couldn't remove all the adhesions, but at least the chronic abdominal pain has resolved. Okay, let's see, how am I doing for time? Oh, good, yes. So those were the 3 cases, and I just want to sort of, before we end, do a couple more things. But basically managing the expectations in chronic SIBO cases, because I see a lot of practitioners referred their cases to me, and I see they did a lot of things right, but then not really soon enough addressing underlying causes. And hopefully that's what I've elucidated here today, is that you don't just treat the bacteria. I didn't even talk about how to treat the bacteria, because I figured you know how to do that, right? You need to know how to actually deal with these underlying issues. So if there's a direct cause, right? So let's say a patient just had some stress, took proton pump inhibitors, developed SIBO. Symptoms will resolve when SIBO is successfully cleared, right? So they will just not have an issue. But if you have other systemic causes of SIBO, the symptoms typically do not improve. Hang on, I've got to move my thing here. Do not resolve when only SIBO is treated, right? So you need to treat the underlying cause with these systemic, if there's a systemic issue like mold, or other bigger problems like dysmotility, as I discussed. So that's important. Meaning that they could be clearing SIBO, but their symptoms aren't cleared, or they're never able to clear SIBO. Like that first case, it was just like on and on and on with antimicrobials. So when we look at the causes, right, I just spent the last hour talking about underlying causes. You're then doing your treatment, and then you're moving into management, all of which can, of course, be also influenced by that person's, what I call the bucket, which is environmental toxins. I think Ellen had the mercury and some lead. Also detox impairments and genomics and microbiome. All of that also comes into our consideration of what's happening with this person. And then also other contributing factors like stress and overwhelm and sleep deficits and all of these things that can really affect our central nervous system and our autonomic nervous system, most importantly, because that governs digestive function and motility. So this is just a way to kind of think about your treatment approach. I also want to let you know that because I'm really passionate about educating people about this issue of underlying causes. This is a free download you can get on the SIBOdoctor.com. That's basically a questionnaire. You can hand this out to patients, or you can have people download it. They fill it out at home and they bring it to you. And that gives you at least a little bit of a head start of what caused this for my patient? Is it digestive dysfunction? Is it dysmotility? Where am I going with this? And then lastly, just a bit of a plug for what I've created, because like I said, I stepped out of private practice and I'm really focusing more on practitioner education, because I think this is where my sweet spot is where I like to teach and I like to educate practitioners. And I've been in practice for over 25 years, so I have a lot of experience. But how you can grow your practice is you can become an affiliate. We do have the biphasic diet available for affiliateship, and also a microbiome course I created for patients. And then also being listed in our SIBO doctor approved database is a great practice grower for many people, because of many patients looking for SIBO, SIBO savvy practitioners look into this database. So the SIBO mastery program that I created is basically 13 lessons. I've listed them all here. Each lesson goes deeply into these topics. So because I feel like if you know SIBO, you know everything about functional digestive disorders, because these are the things that you need to know. Things like intestinal permeability, histamine intolerance, the gut-brain axis, the everything that I was just kind of elucidating here, I talk about in my course. And when you complete it, you get a certificate of completion, and you can actually put your SIBO doctor approved badge on the website. And we are offering a 25% off today for participants of this webinar. And I'll let AC know how long that will go, but you can just put the Nordic at the checkout. So thank you very much for your attention. Here are my handles, and also the podcast is also something that might be a great resource for you. So thank you very much for spending some time with me on your early morning. I don't think it's that early, actually. I think it's 10 o'clock or 11 o'clock now. So you're all good. Should be wide awake. But Gary gets the gold star.
Yeah, he's awake like in the middle of the night. So we have Gary Stapleton on the meeting here, and he's in the US, and he's known to get up in the middle of the night, and I feel very humbled that you're here, Gary. So thank you very much. And thank you, Dr. Jacobi, for this presentation. Yeah, let's fix the SIBO just as a quick fix. No, there's not always such a thing. And
sometimes
I think
when we're lucky, but we don't need help with the ones that are easy. We need help with the ones that are beyond our understanding of what's happening.
Absolutely. So you did an amazing demonstration here of how we as practitioners need to investigate a lot more in certain cases. And when the SIBO test shows all good, then and the patient doesn't feel all good, so that it's not you necessarily failing in treating, you did treat an issue, but there's the underlying issues that we need to go in and work with and see if we can address those, and through that heal the patient further. So of course that the chat box has been like boiling.
Oh yeah.
Lots of things
I
has
see.
come
Okay,
up.
let's have a look
And
here. I'm gonna
I
have to scroll all the way up.
well, I've tried to put some of them a little bit together.
Yeah,
One
okay.
thing that came up was like histamine and SIBO. I think that could be
yes.
just
So there are 3 reasons why histamine can be an issue, an often overlooked issue in SIBO. Number 1 is the destruction of diamine oxidase, which is a brush border enzyme. So if you're lacking diamine oxidase, you can't break down food-based histamine. Another reason for increased prevalence of histamine intolerance in SIBO cases is because of the migration of mast cells into the gut wall in SIBO. We know that happens, and mast cells contain histamine. And lastly, it can be microbially produced. So if you have a case of dysbiosis, that can also contribute to histamine intolerance. So it's very common in SIBO.
Absolutely. And then there was a question like, would you do in the first consultation, would you do a stool test and a SIBO at like
totally depends, totally depends. I'm a specialist, so people expect for me to do more digging, right? So I will do specialized testing based on their test result. I'm not a believer of just everybody do the same 10 tests. I'm very specific with what I tell people to do. And sometimes I have probably 5 different labs that I use for different stool testing, because not everybody, there's not one that's perfect for everything. So yes, and so depending on what I suspect, I will do that. But because I specialize in functional digestive disorders, it's very unlikely for me to not do a stool test at some point.
Good to know. I think with the recording, I'll share our stool test chart overview, so you can just get an overview of the different stool tests we have. So then it's maybe easier for you to pick the right one for the right patient, or for the patient that you're sitting with. I think if we can just move into, because there's a lot of like diets in relation to, now there's your SIBO biphasic diet, there's also the low FODMAP diet is being used, then there you can do the carnivore one was mentioning, there's fasting, and then elemental diet, as you mentioned. And
okay, so elemental diet is not a treatment diet. It's a type of it's a type of antimicrobial therapy. Very important distinction, right? We call it the elemental diet because that's pretty much all they're getting, right? But you don't use the elemental diet along with another diet or something like that. So anyways, I think of it as an antimicrobial.
So you would look at fasting as an antimicrobial as well? And
sometimes I do. I add antimicrobials to the elemental diet, depending on, like what I did with this patient, with John. I added the liquids, but I feel like, first of all, I'm not a fan of the carnivore diet. I know some people have such severe dysbiosis that for short periods of time of really completely eliminating carbohydrates, that works if they have huge fermentation. That's why it works. It'll just kind of stop that from happening. But I've seen really severe dysbiosis following the carnivore diet. So personally, I'm not a fan. Ethically, I'm not a fan, and just health-wise, I'm not a fan of the carnivore diet. It's like I said, it has its role therapeutically for short periods of time. The biggest thing that we know that works is FODMAP. The reason I created the biphasic diet is because still my patients were symptomatic with FODMAP, because a lot of food is still available. And I find that many people that have SIBO, they're quite inflamed. And there was a question, one of the first questions from Francesco actually was asking about nausea, because nausea is also very common, and there's lots of different reasons. But one reason is inflammation and leaky gut can cause a lot of that kind of low level gut barrier inflammation can cause that, besides gastroparesis and lots of different reasons why that happens. Retrograde motility, if methane is very high. Lots of different reasons, but the biphasic diet, I created that because it absolutely is the program for somebody who needs quick symptom relief, because the first phase of the biphasic diet is quite restrictive, and that can be as long as you want it to be for your patient. I basically said 4 weeks, because let's say a patient comes in, you suspect SIBO, they have a lot of symptoms, you can order the breath test and you can put them on the biphasic diet, phase 1, and say, come, let's review the test in 4 weeks or 2 weeks or whatever you want to tell them. And then you see, because it's quite restrictive, it's also a little bit lower in histamine, it's almost grain-free, it's quite restrictive. And most people that have a combination of SIBO, leaky gut, and severe bloating and things like that they will feel better with the diet alone. Then phase 2 is a lot more generous with food. A lot of food comes back in, and then the antimicrobials start. So I did that on purpose. I wanted, first of all, I didn't want my patient to leave with 25 supplements. I personally hate that. I don't want to take fistfuls of supplements myself. And so I always try to stagger it for my people, my patients. Yes, sometimes they are on a lot for short periods of time, but I don't like doing that. So I said, all right, in 2 phases. In this phase, you get this. If it helps, stay on it I want you to keep up with X, Y, and Z product, and then I'm going to add in antimicrobial. So they're already a little bit, the inflammation is already reduced when you start, and their die-off will be less severe.
Super. And then the question around time on supplements or rifaximin, or like, do you have a certain time, some maybe just 1 month and then evaluation, or do you go 3 months or 14
Sure.
days?
Oh, okay, yeah. So depending on the case, right, case by case, but typically with herbs, it's usually 1 round is 6 weeks, and it's not uncommon for somebody to need 2 rounds of that, right? Especially if you retest at 6 weeks, and yes, numbers are down. That's the other reasons I love retesting, is because you need to know if your therapy is working. And if it's, if sometimes if it's an easy case and yes, they're getting better, then you don't need to. And if they're completely resolved at the end of the test, or sorry, of the end of treatment, all their symptoms are good, that's fine. That's not the problem. SIBO was an easy case, but it's not always the case. I'm really talking about these other cases that require a little bit more. So in those cases, so a round of rifaximin is 2 weeks typically. And so that's why some people prefer using rifaximin, because it's 2 weeks versus 6 weeks of herbal antimicrobials. So it all depends on the medication,
So I think time is up, and it's evening at your place. You need to enjoy your fireplace.
Oh my God, all these poor people that have put questions in here. Oh,
and it's so exciting. But we just have to invite you back another time, and hopefully
would love to.
go in person at some of our events, etc. So
well, everything, let me just say the last plug is like, if you got a lot out of this presentation, I really invite you to look at the SIBO Mastery class, because I have put everything in there, and each lesson is about an hour. So you get 13 hours of basically deep diving into what can go wrong in the gut, including mucosal formation, what happens with low mucus formation, like stuff I would never even bring up here. It's just not enough time.
So absolutely look into that. We'll share the link as well in the mail when we send out the recording to you also. So thank you very much, Dr. Jacobi. That was a pleasure and a huge learning curve here. For those of you who want to hang on with me, and just then I'll actually show you where we have a few SIBO protocols in the VMS afterwards. But otherwise, you just log out. And thank you again for your presentation and spending time with us in your evening.
Thank you. Good luck, everyone. Nice to see your faces around the world. Go to bed, Gary. Bye.
Good night, Gary.
Bye-bye.
If you do not already have an account with us, please contact our team and we will assist you. If you found this webinar helpful, please like and subscribe to our channel.